Okay.
Good afternoon, dear colleagues. My name is Dr. Purgin, and today I'm glad to present to you a report on the topic fremanezumab for the preventive treatment of chronic migraine. But before we start talking about this topic, let's understand what migraine is in general. Migraine is a major global health issue. In the United States, the prevalence of migraine is 12% and peaks in middle life from 30 to 49 years of age, impacting patients with in their prime working years. Approximately 1/3 of patients experience headache more than 4 days per month. But who are these patients? Who gets migraine? It's difficult to predict who may get a migraine and who may not, but there are risk factors that may make you more vulnerable. These risk factors include genetics, gender, stress, smoking history, missing a meal, light, and so on. As you know, migraines in women are more common around the time of their menstrual periods, when estrogen concentrations decline in the brain during period, serotonin concentrations decline too. This causes a release of substances that cause vasodilatation of cranial blood vessels and sensitization of specific nerves in the brain that may lead to the symptoms of a migraine. There are 4 phases to a migraine, although not all the phases are necessarily experienced. The first phase is the prodrome, which occurs hours or days before the headache. The second one is the aura, which immediately precedes the headache. The pain phase, also known as headache phase, and the postdrome, the effects experienced following the end of a migraine attack. But today, we will not analyze in detail the symptoms and phases of migraine, but we'll go straight to the treatment. There are various strategies for the treatment of migraine, but today we will focus on preventive treatment, in particular treatment with monoclonal antibodies. Calcitonin gene-related peptide plays an important role in migraine. Plasma CGRP levels increase significantly during migraine attacks and return to normal following relief of migraine pain. Numerous studies have been conducted proving that monoclonal antibodies that block CGRP show high efficacy in migraine therapy. There are, as you know, many different types of trials, but according to the hierarchy of evidence, randomized controlled trials have a high level of confidence. That is why today we will analyze the results of a randomized controlled trial, the purpose of which was to evaluate the efficacy and safety of fremanezumab for the preventive treatment of chronic migraine. To do this, let's take the article in the New England Journal of Medicine that details the study design, primary and secondary endpoints, safety profile, and results, of course. So, what is the design of this study? In the phase 3 international multicenter randomized and placebo-controlled study with intention to treat analysis. Patients were treated at 132 sites in 9 countries. And to better understand study design, we need to answer 3 questions. Who was tested? What was done? And what were assessed? So, who was tested? Adult patients younger than 70 years who had the fulfillment of the criteria for chronic migraine. Moreover, they had a history of migraine according to the criteria of the International Classification of Headache Disorders for at least 12 months. These patients underwent stratified randomization. They were randomly assigned in a 1:1:1 ratio to receive fremanezumab quarterly, fremanezumab monthly, and placebo. After that, clinical outcomes were assessed. And you can ask me, what were the clinical outcomes? The primary endpoint was the mean change in the average number of headache days, comparing the baseline with the 12-week period after the first dose. As you can see, secondary endpoints were the mean change in the average number of migraine days per month, the percentage of patients with a reduction of at least 50% in the average number of headache days per month, the mean change in the average number of days of use of any acute headache medication per month, and so on. You can see it on this slide. Moreover, investigators evaluated the safety profile according to adverse events, vital signs, physical examination, clinical laboratory tests, and etc. And you can see it on this slide too. And what results were obtained? With respect to the primary endpoint, the mean number of headache days was reduced by 4.3 days in the fremanezumab quarterly group, 4.6 days in the fremanezumab monthly group, and 2.5 days in the placebo group. And look at the p-value. It is less 0.001. It's excellent result. What about migraine days? There was a reduction in the average number of migraine days with fremanezumab quarterly, 4.9 days, and fremanezumab monthly, 5.0 days, than with placebo. Significantly, more patients who received fremanezumab had a reduction of at least 50% in the average number of headache days. Quarterly regimen, 38%, monthly regimen, 41%, and placebo, 18%. If you look at the table on this slide, you will see that there was a reduction in the average number of days in which acute headache medication was used in the fremanezumab group, 3.7 days with a quarterly regimen and 4.2 days with a monthly regimen, than in the placebo group. In this slide, you can see the mean change in the number of headache days during the 4-week period after the first dose. Difference of fremanezumab quarterly and monthly groups versus placebo group was 2.3 and 2.4 days, respectively. And you can ask me, what about quality of life? Well, the degree of headache-related disability decreased between baseline and the 4-week period after the last dose, with significantly greater reduction in the 6-item headache impact test scores with fremanezumab quarterly and fremanezumab monthly than with placebo. And you can see it on this table at the bottom of the slide. As you remember, this trial evaluated not only efficacy, but safety profile too. Adverse events were reported for 64% of the patients receiving placebo, 70% of those receiving fremanezumab quarterly and 71% of those receiving fremanezumab monthly. Injection site reaction were reported in 40% of the patients receiving placebo, 47% of those receiving fremanezumab quarterly, and 47% of those receiving fremanezumab monthly. But it's very important to note that the severity of injection site reaction did not differ significantly among the trial groups. As you can see, the most common adverse event was injection site pain. And we have to tell about one incident, one death. This death occurred 69 days after the patient received fremanezumab, but we should understand that it was due to chronic obstructive pulmonary disease complications. So, in conclusion, we can say that this phase 3 trial of fremanezumab in chronic migraine showed a significant benefit of fremanezumab over placebo, and treatment effects were seen within 4 weeks after the first dose. Fremanezumab was associated with a higher incidence of injection site reaction than placebo, but the severity of such reactions did not differ significantly among the trial groups. Mild transient elevations in liver enzyme levels occurred, and the levels reverted to normal without discontinuation of the trial regimen. It's also important to note that further studies will be needed to assess the safety and efficacy of fremanezumab in a population of patients with migraine and coexistent diseases. And our results are not available to assess the long-term effects of fremanezumab on safety. In other words, fremanezumab given monthly or quarterly, it didn't matter, was effective for the preventive treatment of chronic migraine. So thank you for your attention. Do you have any question?